or the lateral subluxation. And the reason you do that is because that is one of the diagnostic criteria. That Scour test, the Inflection Scour test, is a diagnostic criteria for a biomechanical dysfunction of the hip. It's such a good test that even when the hip isn't painful, this will elicit pain, even when it's asymptomatic as far as the patient is concerned. Okay. Think about that. The other question I was asked was, if the patient is so acutely painful, won't this over-provoke the pain? If you have a highly acute patient, very severe pain anywhere, there's no need to do a quadrant. None at all. You either diagnose the exact tissue, or it's so acute, or you can say this is really inflamed, or there's possibly a fracture or something else. And that will stop you from doing any tests that won't give you information that you need. You know this is a severely painful one. If it's fractured, it needs to get x-rayed. If it's highly inflamed, it needs anti-inflammatory treatment, and it needs you to worry about the exact cause of the inflammation for later. The quadrant won't help you with these. So don't do these in acute pain. If you're going to do that, then it's done without compression, very, very carefully, so you don't provoke the pain. Okay? Yeah, is there anything on the quadrants I can tell you? And Dave's right, and I said that to somebody because they was asking about how you do it. You've got a class coming up. It's a lot easier to do these than it is to describe the quadrant or the P&F pattern. These are not easy things to describe. Describing quadrants is one step less difficult than describing P&F patterns.
So, Jim, I have a question about what you just mentioned on the acute pain.
Come on.
I had someone come in for a screen the other day for elbow pain, medial and lateral epicondyle pain. So, and I just watched the elbow video. So I went through, kind of the quadrants and trying to piece out that. It's the kind of thing where I knew going through that movement wasn't going to, flare it up like some quadrant test would maybe for the hip, but I just kind of wanted to piece together where I thought some of the dysfunction was happening. And I don't grasp it enough to know from that, I guess. Would you still do that? I would assume you'd do that for the elbow typically, even if
no. I think what I would do with an elbow is, like, I've got a system for doing this for myself. But if I know the elbow's in trouble, then generally speaking, I'll go through the standard biomechanical tests. And it depends on what I've got my diagnosis. If this is a biomechanical dysfunction of the elbow, and I don't know which part of the elbow, then I'll do medial and lateral gliding of the ulnar-humeral joint, superior and inferior gliding of the radio-humeral joint, and then glide the inferior and superior radio-ulnar joints. And that does it for me. It's quick. It is specific at this point. I know what I'm finding, and that'll work it for me. If you want to do the quadrants, absolutely you can. And there's no reason not to. It's just not what I would tend to do with the elbow. So, yeah, I mean, basically, there's the ulnar-humeral joint flexion. Pronation and extension is ulnar-humeral extension. Pronation, flexion. So you've got all of these. There's no reason why you can't do that. But eventually, you're going to have to go back in and do specific glides on specific joints. So actually, under those circumstances, I find, the quadrant is going to be positive. If they got elbow pain, the quadrant is going to be positive for pain. You may or may not be able to sort out the ovoid of motion, and that won't give you really a lot of specific information. So given that this is painful, given I've taken a history from them, I've done, and what I should be doing now is also doing an objective exam of the elbow, so I can turn around and say, yes, this is a biomechanical dysfunction. It needs a biomechanical exam. I'll go straight to specific biomechanical tests. Is that okay, Mark?
Yeah, that's helpful. And I'm sure, obviously, we'll see more of that this weekend.
Yeah. But the process is always the same. Processes don't vary. You can add screening tests on, or you can take them off. But the actual definitive testing process doesn't change. You make your diagnosis of a biomechanical dysfunction, you go and do a biomechanical exam. That's it. There's your processes. So under the processing is easy to grasp, very easy to grasp. And in principle, in detail, you have to add in this joint, that joint, and so on. But in principle, it's really easy to grasp. Make your diagnosis based on non-biomechanical questions and testing, then make the biomechanical statement from biomechanical testing. It isn't any more complicated than that.
Yeah, a couple examples, like, okay, this morning, first patient was, lateral elbow pain, tennis player. Normally it'd be a biomechanical exam, but, I just basically did the quadrants, and, I could tell right away that, okay, his extension pronation quadrant was positive. So I'm thinking, okay, it's an abducted on, I felt it. I had somebody else feel it and went over the quadrants. By the time we did it and mobilized it, it cleared it up. So by the time I came back to it again, it had already opened up, but the quadrant was tight when we both tested it. So the quadrant, in a sense, ended up being our treatment. But it ended up being a joint glide because we did it so much. So it wasn't really jammed to the extent that it wouldn't free up with that type of mobilization.
How did you know it wasn't a fracture?
Hmm?
How did you know it wasn't a fracture?
Severity. He just finished playing tennis for 45 minutes.
You took a history.
Mm-hmm.
There was no trauma, was there?
No.
You took some other history as well, I'm sure.
Mm-hmm.
Have you had it before and so on?
Yeah.
And then you did flexion extension of the elbow, didn't you? Find out if there was an arthritis there.
Yeah.
And then you moved to the biomechanical exam. That's what I'm saying to you. Your first step is to make that diagnosis of biomechanical dysfunction and then do a biomechanical exam.
Yeah.
Processes don't change.
Yeah. The reason I did the quadrant this morning, because we're doing quadrants. So before I did anything else, I know the guy. I've seen his elbow. So I'm like, okay, let me do the quadrant and see what I bump into. So I just
okay. What sort of bias is that called?
Huh? Oh, geez, you're putting me on the spot on the biases.
Just learned bias. Well, what is that called when it comes to mind?
Recency bias.
Yeah.
Oh.
Yeah.
But a better example is, okay, in the shoulder, I may use a quadrant in the elbow when I'm dealing with a shoulder problem to quickly go through the elbow and look for something versus doing a complete biomechanical exam on the elbow.
That's exactly what it's for. Really, I'll tell you the history of this. The Australians developed this. I don't know if they took it from somebody before them, but this goes back to Maitland in the 50s and 60s. Mm-hmm. They developed this as a test of last resort. Everything else was turned up negative. They couldn't figure out what the hell it was. So let's try a test that will show us at the end of this that we can now use. And that went on for years. One day I thought, well, if it's that bloody good as a test of last resort, why isn't it used as a screening test? If it's so good it picks up stuff that your regular testing can't do, put it on the front end and not the back end. So the ideal use of this is to screen when you don't want to waste time doing exams on joints that don't need it.
Yeah. Like, I guess this common would be the hip, when you look at the hip quadrants, is understanding the relative motion I have there in pain production. I'm looking at a knee, ankle, or even lower back. I mean, I'm usually looking at the hip quadrants just to make sure, can I move through all these quadrants cleanly without pain or
yeah, you can move on. You can move on. That's exactly right. The problem with the way a lot of this talk, like for the hip example, I'm willing to bet you that you learned one test as a quadrant, which is the inner scour, and it may not even been called a quadrant. Tell me if I'm wrong here. You learned that test as a scour, and you learned Faber's separately, which is the other quadrant, flexion quadrant. So am I wrong in assuming that? Or and you never learned extension quadrants? Is that a reasonable assumption?
I at least don't remember extension quadrants.
I don't know anybody who hasn't taken not even advanced courses, more courses, who knows about extension quadrants of the hip or the flexion quadrants at the shoulder. They give you bits and pieces. The more you know about quadrant testing, the more use you can get out of them. But if you, for example, if you only do the quadrant scour and you don't do the extension quadrant, you're going to miss extension hypomobilities.
Yeah. Yeah, I mean, the extension quadrants are almost more important to me than the flexion quadrant.
Yeah, except for pain.
They are.
Yeah.
How much extension are you putting
Full
their
extension.
hip in?
Full extension. Stabilize
Like
the
30?
system, hold it down, put it on. All of these movements are full range. This is why you get to the barrier. All of these movements are full range.
You stabilize the pelvis and lumbar spine. I thought I heard you say 30. It won't be nearly that much.
No, if you stabilize the ischium, push the ischium down, you're lucky if you get 10 or 15 degrees, if you get
Okay.
that. Yeah,
That makes
full
sense.
range. But isolate the movement as much as you can. For the hip, if you're looking for especially if you're looking for the ovoid, if you're looking for the ovoid of motion of the hip, stabilize the innominate. It's a bit more difficult to do under compression, but if you can do it, stabilize that joint. Shoulders, stabilize the scapula. When you can stabilize it, particularly for the ovoid of motion, do so. Actually, even for the pain, because you want to know the pain is actually coming from that joint. If you don't stabilize the innominate under compression, it could be the SI joint again. Then you got to screw about now. Is Fortin's test positive? Well, actually, if they got groin pain, Fortin's test is going to be negative. But objective Fortin's will probably be positive if the SI is in trouble. It's like everything else. There's one of the problems you've got is the people who are teaching you techniques and tests and treatments are good at what they do. So it looks as if they're doing it casually. There's nothing casual in the way they do it. Have them do it to you and it won't feel casual. If there's need for stabilization, you'll feel that when the instructor is doing it. It looks casual and easy, but it isn't casual. This is very deliberate, these tests and treatments. Volunteer to have this done to you. If you're not doing that now, it's always worthwhile.
Yeah, it's you'll find you're very good at, there's a certain specificity to it when somebody does it who's you know, you do it a lot. Like you feel Eric do it to yourself, be like, oh, that's very focused compared to just stability.
Okay. Don't look at it and say, well, that's easy, and it's just a casual thing. It isn't. It just looks that way. Because it's difficult to screw up when you know what you're doing. Anything else, guys?
I think Jenna asked, I guess, a question regarding, you know, way to perform passive range of motion of the shoulder, asking why do you put the elbow in full flexion?
Because it's, well, you don't actually. What, for the quadrant?
For like just the shoulder flexion when you're like in the video, it was like full elbow
That was a
flexion
quadrant.
and then coming up. Okay, that was the quadrant.
That was a quadrant. But you've got to get a grip on the limb that you're moving.
Okay.
And sometimes it's just easier to bend the elbow and to move the shoulder. It's really about, it's pragmatics more than anything else. Are you thinking about tightening the muscles up?
No.
Okay. All right. I'll give you more credit than I needed to then. That would be a consideration. If you thought it was the muscles, then you're going to have to find a way of doing it without flex. The ankle dorsiflexion is a really good example of this. If you do dorsiflexion of the ankle with the knee straight, you will never feel a capsular end feel unless there's a problem in the muscle or the joint capsule is hypertrophied, seriously hypertrophied, because gastrocnemius will prevent you from getting to the end of full dorsiflexion of the ankle. So there is an argument, the argument I thought you were making is a reasonable one sometimes. If you believe that's affecting it, then change the way you're testing. But if you're looking at triceps limiting flexion, it's a bit of a stretch, but it might be, in which case you're going to have to do it without. But mostly you hold things the way you hold them because it's easier to do the thing you want to do.
Yeah, that's kind of with Deb. Thanks for bringing it up in the video. It's the way Eric did a video, and he mentions that again. He likes to flex it and to give him better control of the glenohumeral joint. That's kind of what Jim is saying, is that with the flexed elbow, you have a shorter lever arm. It's easier to control the arm when the elbow is bent with the shoulder moving through a range versus a straight arm. That's what Jenna's initial question was. I can't ever say I do a quadrant with the elbow extended. It's always been flexed, and it's just because it's far easier to handle, especially in the ovoids of motion.
Yeah, if you think about it, if you're going to do flexion with the elbow extended, they're going to have to work the triceps to stop the elbow flopping forwards anyway. So you get the same effect. But thank you for subtitling what I said, Dave.
Yeah. So I just sit back and I repeat it, and then hopefully I get the credit for the the intellectual statement.
That's the principle of the last one who speaks, is it?
Yep. I'm the intellectual remora, just feeding off the scraps.
Right, guys. If you've got any other questions, email them to me. The questions, the people who emailed me, I emailed them back and I sent a copy to Dave, so they're all posted. Yeah.
There's a couple of things. Jimmy, want to talk a little bit about the questions that they should be. Let me see if I posted them, because I have a groin pain presentation coming up, and I did post the so far so good. I didn't post the list of questions yet. Do you want to talk about that a little bit since you're here?
No, I want them to answer the questions.
Jim.
The next video you're getting is a self-assessment on where you are with these topics. There's 3 categories of question. There's about 4 or 5 questions in each one. And basically it's about diagnosis and differential diagnosis. And one of them, I've given you the diagnosis and asked you for 3 diagnoses, one of which is based on bias and error, one of which is based on, what else was it? Overlapping EISs, where the outlier of one condition looks like the EIS of the one you're considering. And the other one was, oh, damn it, can't remember. Anyway, the test will make you think. I think what you should do with it, I think, first off, you should do it. It's not mandatory, do it, don't do it, it's up to you. I think, first of all, you should do it, and you should do it properly. Take a pencil and paper. Don't try and do this in your head, because you'll manipulate what you said when you do find out the answers. Just write the answers down and then go over them. The whole point of this is to fail a bit so that you can learn from the failure. But go over it on a piece of paper and so on. I also suggest that you send your answers to me, and because this is helpful to us. If there's a consistent problem in an area, we know what it is and we can see what we can do about it. Okay, from our perspective, that's what it's about. Also, if you do it, you'll get some idea of the quality of the questions you're going to get on the section that will be looking at these videos in the final test. So, and then I'll publish the answers, or Dave will publish the answers, or I might even do a video on it, I don't know yet, in good time, all right? So I think it's going to be extremely beneficial to you, not just as a self-assessment tool, well, yeah, basically that, and also to understand where you might be a bit weak, all right? Yeah. This is not an easy test, all right? And nobody's going to grade it. All right.
I think you may be surprised at the differentials that you'll feel like, okay, you're much closer than you think you are.
Yeah.
That's really the important thing to be looked for, and this is the clinical reasoning.
I wouldn't be surprised if that's the case at all. So you tend to block stuff because it's too difficult. But even if you're picking up stuff by osmosis, it's got to be in there somewhere. Okay. But it's not an easy test. I don't think it's easy. But let me know if it is. I'll be delighted if you find it easy.
Yeah, like some of the elbow biomechanics, I don't expect anyone to know right now.
Yeah.
You know, that you'll get that after the course, and having the question ahead of the course, you can then, okay, go to Eric and, talking you through it so you understand it. But I think that's also important too, because then you'll see the relevance of the conversations we had, the differential here's the question that I bumped into when I tested a quadrant or a movement pattern. And then you'll be able to go over with Eric. So that'll be helpful.
So are you going to post that before the courses?
I realized I put it in, I posted it on the Zoom. I didn't send them the handouts, the PDFs, but I posted your presentation.
Okay.
But I don't want them to stress over because of the elbow and the peripheral stuff being in there, that they haven't had the peripheral, and that our expectation is.
But no, I don't think they need it. I don't think they need it. I think all they need is the principles, pathology, really. This is all stuff that you should have been able to do from school. In all honesty, all of the stuff on that little self-assessment test is stuff that they should have taught you in school. It's about anatomy and pathology diagnosis. That's it. Nothing you haven't come across before. But I think it's a somewhat different. It's a very different way of putting the question is, what's the differential diagnosis? Because I want some explanation of why you do that. Oh, the other one was, I'll give you a group of signs and symptoms. You make the diagnosis, then make two differential diagnoses in order that you prefer, and then explain the reason you like that order. It's all about making you think. Okay. And it's a bit, for me, it's a bit like pulling legs off of a spider. It's entertaining as well. Okay. But don't worry about it. These things are not going to get great. I'm not going to grade. I've got better things to do in my life.
Oh, Jim, that's not true.
Yeah. Should have. Oh, I've sold my condo in Airdrie, by the way.
I'm sorry to hear that.
I'm not. Sold
Probably a
it.
good time to sell it, right?
Yeah. Yeah.
Where
All
are you
sad
gonna-
about it, but there
Where are
you
you
go.
going to stay when you teach in?
Oh, no, that's a business condo. I had a clinic in.
Oh, okay, gotcha. Yeah.
Yeah. All right, guys. Contrary to what Dave was saying, I do have things to do. They're not particularly important even to me, but nonetheless, unless you've got any more questions for me, I'm out of here. Good. All right. Good luck on the weekends. Enjoy it. All right.
Thanks, Jim.
Take care, everybody. Bye-bye.
All right. Jim's gone. Anyone have any questions for me about that?
I think having the handout would be helpful, like for the answers
Yeah,
instead of like the video.
he won't be able to help himself. He'll put it together. He actually loves
Yeah.
this. This is his favorite portion of it, so I won't be able to stop him. That's why once I suggest it, he'll do it. If not, we can put it together. And it's a good
handout would be good.
exercise. There's also, I will look through some of his old manuals. He had like lists of these types of questions that were there. So you will be able to
Nice birthday
we'll be able to
cake.
kind of pull those out and use them.
Did you see the balloon behind you, Dave?
Huh?
Did you
Have to
see the
move a little
balloon
more to my
behind
right.
me?
Okay. There we go.
Yeah, scoot to your side, please, Dave.
Yeah. Trying to think of what else. And again, I don't want anyone stressing over quadrants because in the scheme of what I do in the day, quadrants are a very, very tiny portion of it. This is just becoming such a big portion of the conversation. I didn't want everyone going sideways with quadrants. And as I said, when I use them, ironically enough, it's really just the back of my mind thing. I'm doing quadrants, not thinking about it. I'm just scanning through joints and seeing if I bump into stuff. You know, and that's how I'll look for it. And then I may find something, and then I'll go look at a joint further. And it's usually because I have a shoulder, and I'll go through the wrist, or I'll go through the elbow, and I'll screen it with a quadrant. I want to do maybe the full
Okay.
biomechanical. When I bump into
So
something or something doesn't feel right, then I'll do it.
And are you just saying it's dysfunctional and then kind of going a little bit further into it, Dave? Is that how you're kind of
So I'm looking at
processing it?
if you think about it in like the shoulder or an elbow, I mean, it could be one of those ones where, okay, there's something going on in the shoulder. I want to see how the elbow is functioning. I want to be able to screen that in the wrist to see, is it throwing off shoulder mechanics? Because if I have something that I have to alter my elbow mechanics with biomechanically, am I using my shoulder for it? So is it a stressor in there or something I need to address? So that's when I come in the quadrant. And if I bump into a motion that feels tight, then I'll look at the biomechanic exam. If I go swing through the quadrant and I don't feel anything, then my mind just keeps on scanning. I don't do maybe a complete biomechanical exam on the elbow unless it's indicated. And I'll do the same thing. I'll put up a video of Jim. It's from probably one of the modules 7s or 8s, where he basically goes through the quadrant scanning, looking at somebody with shoulder pain. And he does cervical, he skips shoulder because he's looked at the shoulder. He does elbow and wrist. And that's kind of how you end up using these quadrants as this peripheral scan for the joint. I think the hip is valuable. I think Jim said, and I was going to lead him on the hip to get there, is that we often don't look at the extension quadrants. The two quadrants we look at the most are the flexion quadrants. And to be garnered, most of our people have a problem with gait. And it's not so much the flexion quadrant we're going to see it in. You may pick up the arthritic pattern in there. But quite honestly, when you're going for an arthritic pattern, you kind of know you have it before you get there. Where you'll pick it up early is the extension quadrant with extension internal rotation. So, I get way more value of, I want to know what the hip does in extension. I'm looking at a knee or an ankle. It's like, I want to know it. And I know I have to do all the other stuff first before I get there. Because once I understand what the hip gives me, then I know what the rest of the body can do. If my hip can't give me extension internal rotation, then I know how they're going to have to adapt. They're going to have to adapt with external rotation at the hip. They're going to be flexed at the pelvis. They're going to have different compensations, coming around it. It's going to change what the ankle does. So I know that if I have this hip that can't extend and internally rotate, then it's gonna be harder to address some of the other joints biomechanics that have normal range because they'll have to compensate for the hip. So the hip screen in Quadrant is a valuable one beyond the Faber and Fader. Anyone who works with me knows I'll go right to the hip and I'll look at the internal rotation extension quadrant and put a lot of value in it. I will also, with the internal quadrant, I will test it blocking it and look at pure hip motion, which is what Jim talked about, which would be very limited compared to the full one. And I think other people are used to seeing maybe, somebody mentioned like 30 degrees. So I will come back and look at, as I lift the hip up, am I driving into the lumbar spine? So more of a module 7 thought process is first I want to understand what the hip gives me. Then as I extend the hip, okay, what is easy to go into? Does the innominate move first and fast? Do I drive it into L5S1? So I'll look at extension and I'll work my way up in extension just to get a tendency. I should see that tendency in standing. That'll follow through. This person hinges in extension through L5S1 at that segment. How do I test the hip quadrant if they can't create into prone? It's very rare that it can't for long enough to do that, but I probably see a healthier population. I would do it in sideline, best I can. And you'll get a
that's
sense.
kind of what I figured.
It's crappy to test in sideline because they're going to tone. So it's never going to be good in sideline. When you're looking at hip extension in sideline, you're always dealing with some level of probably psoas tone just to try and stabilize the joint. Much like your rotator cuff muscles fire when you're doing, I can't remember the classic shoulder stretch, the internal rotation at the side, that stretch. Like they find that rotator cuff activation with that test is relatively, moderate. The whole rotator cuff is firing if you're trying to do that classic stretch test. So that's kind of guarding that stress test. Same thing with the hip and sideline. I get way more tone in the flexor group trying to prevent it because of the extension moment, probably in the lumbar spine. So I find it less valuable. So I have to kind of look at it in sideline with a bit of that in mind, that I'm probably going to see less motion and it's going to be less pure and get more muscle tone and guarding. Yeah, again, I'm lucky. I want to see debilitated people. I hang out with Dylan. No, it's just funny. Our office have different demographics, so going between them is always kind of nice to see. But again, it's still the arthritic population. It's good to know what the hip can do. Because it's going to dictate if they have an early, and you'll see it early on in people that inner extension quadrant will be limited, and they may not even have much arthritic pain, but it dictates what's going on in the lumbar spine and hip. So, and I've seen tight hip quadrants, which looks like a capsular feel, and they've had hip x-rays at times and they've been completely normal. So it's also understanding that person's body makeup and what their pain is. So if I get a tight quadrant in the absence of pain or pathology related to the hip, I know that this hip is going to dictate what happens at the lumbar spine and around it, but the hip itself may not be pathological. And if it's capsular, good luck stretching it. The only people I've seen do it really well, that people were really dogmatic about it and basically stretched it all the time and were religious in type A. Okay, hip quadrant with the labral tear. I would expect to find, think about the labral tear is I could see anything from, you probably may get a positive UFR test with the labral tear. So what I expect is that internal rotation quadrant and some maybe internal rotation extension may be irritable and limited, depending if my femoral head is seated anterior in the socket. I may get that. Certainly in your flexion quadrants, your flexion internal rotation quadrants tend to be painful and irritable. This tends to be clicky. But it all depends on you have to kind of get a sense of, in the later modules, can I reduce the femoral head? The femoral head is kind of sitting anterior, it's going to create a lot more stress in it. The femoral head hasn't lost its posterior glide and its ability to center in the joint, then you may get the full range. But generally with the degenerative labral tears, you're going to find this internal rotation motion is going to be fairly restricted, as well as the extension quadrant. But you'll be positive or for pain in your flexion internal rotation quadrants. And depending on how it's irritable, possibly the external rotation quadrants as well, as the femoral head creates pressure on the anterior labrum and capsule. The U for correction many times will take the femoral head off of the degenerative labrum. So I'll put it this way: anyone you find the UFER is effective in, you assume that they have a degenerative labrum or some stretching of the anterior capsule of the hip. Because to get the UFER, you have to have a bit of micro instability in the hip for that femoral head to translate a bit anterior and kind of seated there. So for it to kind of glide forward in the socket, you probably have a bit of that going on. And many times what you're going to do, if again, it's kind of like if you manipulate the UFER and now you restored its posterior glide, you will take stress off of the anterior labrum. So you can make some anterior labrums feel a lot more normal and get the pressure off of them. That's mine. Every now and then I can use a good UFER manip and it'll help reset my hip and my hip will recover faster. And if I don't do stupid things or I kind of keep my activity level moderate and work around my hip, it does quite well. Typical UFER, you manipulate it and these people love you and they go about their business. You know, the labral tear, if it is a labral tear and it's aggravated and inflamed, it's a drop in the bucket. They will feel a little bit better when you see them, a little bit better that day, and then as they get back to what they're doing, their pain will come back. They'll sleep overnight, the hip will reset. And so depending on how inflamed it is and how irritable it is at that period of time will dictate how they respond. If it's really inflamed and irritable, then it's going to be a little bit of help, but it's not going to be sustaining. If it's more in the moderate range where you see a lot of people there, then it'll be very helpful. What I also want to be able to do with them is also make sure that they can properly work on seating their hip. And that is, you know, the thing between pelvic floor stabilization, you know, looking at foot angles, hip angles, how they're moving, are they stabilizing their SI joint properly, and single leg weight transfer. You know, these biomechanical things go a long way. So getting the UFER set, the UFER is an effect in a sense. It's happened to them. And once we get it corrected, we need to kind of also address the cause. That's the cool thing about this. I think like what we teach should be almost the smallest part of your time with a patient. You should be able to do these things quick and efficiently. And then you're on to your motor control and retraining, trying to reset the problem and do these other things that they're going to need. But if you have a UFER sitting there and you do an hour of motor control and resetting things, they're going to leave there and regress right to the familiar because you never got the problem or the primary limiting factor. So you need to find whether that limiting factor, whether it's a you know, is it a SI joint control issue? Is it a anterior hip subluxation? You need to be able to find these things. And that's hopefully from this program, what we're going to do is help you identify these kind of cool things that are out there and then overlay what you normally do in your treatments. He's pretty too for the navel tear. Yeah, Eric will probably go over some hip. You will be able to keep him away from the hip this weekend, is my guess, which would actually be really cool because he'll have a nice take on it. He does a good job teaching. It's a good. I'll be out in module. You get my take on it. I'll give you my take on it in module. I'll be at module 6 in Iowa. I don't know if I'll be in Chicago for that one. I know Rebecca's going to be there, but I don't know if I'm going to come out for that one or not. But I'll give you my take on it and things because if you look at a lot of the literature, there's a couple of terms that are out there in radiology literature. Micro instability of the hip, it's been around for a while, but it's starting to catch on as this hip model. And this UFER and this labral breakdown degenerative model exists within that micro instability model I didn't talk about. And you see more and more people now adopting it. I've seen it in a couple PT papers now too. So it's kind of come over some, but that's really what you're looking at. And this would be that anteriorly translated femoral head. You will see this a lot more. So I'd say UFERs are a subset in the anteriorly or anteriorly medially translated femoral head, which is kind of comes from Shirley Sauerman and Diane Lee, who are the ones who've kind of talked about it and published on that the most. Fellows in here, if you should have the pelvic girdle book by now. She has a nice big section, and it'll be a big part of what you kind of look at with that, which she'll talk about just the femoral head centering. Okay, time of questions. Yeah, Jenna's question is good. Hey, Tanner, if you have anything you want to chat about, think about what exercises to perform for a hip and lower extremity core for labral tears or keeping a UFER correction. Think of a movement pattern. What movement pattern requires the posterior glide of the femoral head? That's usually what's missing. So you will often see a hip that if it's anteriorly subluxed, the ball sits forward. This is a terrible example. Okay. Oh, here we go. This is the posterior glide coming towards you. Okay. It's going away from me. If the hip is centered anterior away from you, then it rocks. So the anterior hip can have a medial rotary component, an internal rotation component, without a posterior glide. So it's more of a roll. So what you'll feel is, if you feel the anterior hips, you're going to feel more pressure right under about, if you go down the inguinal ligament halfway and drop right underneath of it, you're going to feel pressure in the soft tissue there of the femoral head being anteriorly translated. So think of a femoral head that can be anteriorly translated and also still be able to internally rotate or medially rotate, but not posteriorly glide. So it's lost the glide, but it can still have the rotary moment, which will create a lot of stress in it. If that makes sense. That helps me a lot because the posterior glide is what resets the hip off the anterior labrum or anterior joint. Okay, Tanner, running mechanics and faults. You will see this hip classically in the overstrider. The individual who, again, has a long time on the ground or too long on the ground, trying to overstride to get time or distance and not a faster cadence. And if you think about it, it's how the hip translates anteriorly in the socket in late stance. So you're going to get a lot more stress on the anterior capsule, anterior labrum, if the foot is lingering on the ground longer in late stance, or the foot doesn't come off the ground fast enough with forward propulsion to get the stress off the anterior hip. So that foot that's on the ground too long, you will. So, with that is their main correction is going to be shorten up the stride length. You'll see this in marathoners, usually about when they get to about 18 to 22, and then they'll come in with anterior hip pain. And it's because as you get tireder and you get these longer runs and more stress, your cadence goes down, your time on the ground contact goes up, and the amount of extension moment you get to the hip increases. So by shortening their stride length, you can take a lot of the pressure off the anterior hip. So this is somebody you're going to see kind of doing that. Could also be somebody who just has a lot of collapse of the hip. That's a common pattern that I would see and where it happens in the run cycle. How far out would I do a UFR? Yeah, I wouldn't be doing it real soon, would I? No, I mean, I would probably be looking pretty far out before I went into the UFR on them. Would I mold it and work on the posterior glide? Yes. Will the manipulation damage anything? Likely not. But I would probably do other things early on, just out of an abundance of caution for myself. But I would, if you think about setting them up for the technique and doing oscillatory mobs, you can do like traction, internal rotation. Really what you're looking at doing is trying to recenter the hip posterior and restore the posterior glide. So anything that would kind of help you do that would be reasonable.
That makes sense. That's kind of how I've handled it.
Yeah, and what you want to do is, how can I nudge this back into place? Kind of like the elbow today. It's like I didn't even manipulate the abducted ulna. We just played around with it and molded it with the quadrants. And when I came back to it, it had cleared up by the time Emily had finished with it. So his quadrant was cleared and his movement improved, but I didn't need to manipulate it. So with some people, what I want to do is apply these biomechanics to them. It's not always about, man, I'm going to go and manipulate you right away. I'll just apply I would apply the biomechanics and see, okay, can I nudge this thing free with the biomechanics? And if I can't, then I go manipulate it. I do that a lot with, I think I have an anterior subluxed hip, especially if it's female, especially if I don't know them. Then I will talk them through it, and I will do two things before I do it and say, listen, here are the techniques we are going to do, and we're going to progress through this. So the first thing I do after meeting them is not whack them in the side of the hip. It's basically like a date. I have to sweet talk them a little bit, be nice, all the things I don't do on a second date. I have to do on the first date to kind of give them confidence in me, so I don't seem like some leery guy who just smacked them on the hip. No, maybe what I am. Good videos comparing regular striders to overstriders. I will look. There's a whole running course, and someone had asked about how do we apply this in running? We did a running course with this. Gail had done it, and Fred, and I picked it up and taken their material and gone a little different places with it. I have it. I will pull it together, I thought. And I thought if you wanted, we could do that and look at some of that material after everyone's done the peripheral manipulation module. That way it'll be much more relevant than pre-manipulate, than pre that. If I do it now, there's really no point to it because I can't take you from ankle to hip or TL junction and back down again. Once you finish this course, we'll be able to move through the lower quarter in different ways and then talk about the influence. How does a big toe influence what I'm going to do with my hip? And if any of the fellows out there want to pick that up and make that their thing and teach with it, other than Tanner Newberger, he's already good. Then we can chat about that. I can get you the material. You can update it, do it, maybe teach it in Athletico as a course. So if any of the fellows are interested in that, I'd be happy to pass that along.
I would be interested in doing that.
Okay.
Dave.
Okay, 815-590, is that Drew? No. Yeah, and somebody talked about the running analysis course on MedBridge. What one of the other fellows talked about doing too, and I talked about this with Travis maybe 2 years ago before the world ended, was kind of that thing as we looked at kind of taking some of our courses and could they be hybrided with the MedBridge courses. And I have a fellow right now that's interested in that as well. Because if you look at the MedBridge courses, they're good. They are base package. They are like residency level good. But if you watch the MedBridge course after this peripheral module and see, you'll see everything that's kind of missing in there where it doesn't go to that deeper dive. So one of the thought processes we have had, if it was going to be a residency or do something with them, was do you take a bit of the MedBridge content and then could you overlay what we do after it? So you could do the MedBridge, okay, you do a MedBridge running course, but then you see what they're not going to look at the hip this way. They're not going to look at TL junction. They're not going to look at the ankle this way. So you start to take, here are the basics in a running evaluation, but now here's all those missing pieces that if you apply just that MedBridge course, it's why that person doesn't get completely better, or you don't fix them in one session. The runner with the anterior hip that I talked about, the marathoner, I can fix that many times in one session because I can manipulate the hip, hit another joint if it's done, retrain the running pattern. And when they go from pain to no pain, pain to no pain on the treadmill, you know, it doesn't take much convincing that I should not run in the painful pattern. Coupled with the fact that once I change their running stride, they are faster. They will typically PR because the overstriding mechanic breaks them down and they're actually slower. So that's where you get good buy-in, as long as something hasn't completely broken down in them. So that was just one thought too, Jen. If that's something that interests people, I have a PT right now who's been doing the tennis courses. The fellow has been thinking about that, and that was one process we had of, okay, how do we layer that over there, which probably be a really nice product. Good. Anything else there lingering in the last minute or two? Hope this wasn't too tangential, but I'll admit it. And I wish I'd look to see if I could make it out there for some of the course next week, and I just couldn't arrange my schedule such. So I'm super excited about the peripheral manipulation course. I like it. I use this stuff all the time. So I find it, though it's a content-rich course and be a little overwhelming, you have 4 of the courses to really get it solid. But these are things that I find are super helpful. You can kind of work your way through an ankle this way that's different, or move between these joints. This is bread and butter. I think you're really going to like it. And it's not that you're going to change what you do. You're going to overlay this, what you're already doing with this. And it's a really nice course. So again, never think that you have to forget what you've already learned. Just see where this fits in the scheme of how you treat.